go. Hi, everybody.
Hello.
Welcome. Sorry we're late. We had a fire drill. Code red, all clear. We're good. Thank you all for coming this evening. We're happy to have you. It's May, and that means it's National Osteoporosis Prevention and Awareness Month. So once again, we are here presenting our VVU University presentation. And this year, all of the VVU presentations are going to focus on the physical therapy aspect of the illness or the disease being presented. And we're going to do the same this evening. So our lecture is about exercise and bone health and how to prevent fractures. I know a lot of you out there at the community, Susan Inscore, an internist. I've been a hospitalist. I've been a primary care provider. Now I'm focusing my time in primary care. I'm sorry, in ortho doing bone health, and I get to the privilege of doing that. Jessica.
And I'm Jessica Galgiani. I'm a physical therapist here in outpatient rehab at Valley View in Glenwood. And I see a variety of orthopedic, osteoporosis, and vertigo and neurologic patients. And I've worked closely with Dr. Inscore and the team over the past year to help develop physical activity guidelines to
Now. I will. So again, this is our exercise for bone health and fracture prevention. I have to read a little disclaimer, so bear with me. You can submit questions through the Q&A chat at the bottom of the screen, and your question could be answered during the presentation or at the end during the Q&A portion. We'll try our best to answer all your questions, and if we're unable to answer questions regarding your personal health information. So let's go ahead and get started. Are you, who's again, this is our introduction. You met Jessica. Amanda Hunter is also here with us this evening. Many of you know Amanda. She's a PA in ortho who's worked primarily doing shoulder work with Dr. Leota, but now spending half of her time doing bone health. So many of you have seen Amanda. She's really helped us shorten our wait. So why is osteoporosis important? Because it's a disease that's relatively silent and asymptomatic, it steals our bones silently without us knowing. And a few people may have symptoms such as loss of height up to 1.5 inches or more, or a dowager's hump. The majority of people don't present until they break a bone or have an abnormal test. One of the biggest things that has made me a little crazy over my career, especially seeing so many fractures in the hospital as well as in the clinic, is how we are underdiagnosing and undertreating osteoporosis. If you look at our statistics and you look at patients that might present with a fragility fracture of the vertebral, one of our spinal vertebral bodies or our hip, only about 20% of patients are having a DEXA or being offered treatment within 6 months of that fracture. So up to 80% of our patients are being underdiagnosed and undertreated. And one of my goals before I die is to change those statistics, at least in our community. Fractures can be deadly. They frequently lead to the loss of independence. And we know that about 30% of elderly patients with a hip fracture can die within a year. Again, many end up in a nursing home. We lose function and frequently end up using a cane or a walker. That leads to less movement, less muscle, and an increased risk of falls. And many patients have chronic pain after a fracture. We don't get to go backwards after we break a bone. So our focus is on trying to prevent osteoporosis and broken bones when we can, and aggressively treating it so that we can save lives, maintain independence, and help preserve function. These are going to be well, I had objectives, but that's okay. That's okay. The objectives tonight are to define osteoporosis, which is our next slide. And then Jessica's also going to outline for us some of the guidelines using clinical evidence for bone and muscle support. She's going to help show us some safe ways of doing our exercises. She's going to help us use more safety, especially when it comes to the spine. So osteoporosis is defined as a systemic skeletal disease characterized by low bone mass. That's what our DEXA, or our bone density test, checks for, is low bone mass, and microarchitectural deterioration. That's what our trabecular bone score, or TBS, tests for. And when that disease occurs to bone tissue, it leads to fragility and susceptibility to fracture. It occurs when the rate of bone resorption exceeds the rate of bone formation. And no talk would be complete without a slide about bone remodeling. Bone is dynamic. We build new bone and we break down old bone every day. And we all know that our osteoclasts are busy cleaning up old bone or helping heal a microfracture or a crack, while our osteoblasts are helping lay down new bone. And in the process of not being able to produce as much new bone, the bone resorption exceeds formation. Many patients confuse osteoporosis with osteoarthritis. Porosis is the loss of bone density and bone microarchitecture that you see on the left side, whereas osteoarthritis is more a loss of the cartilage between the joints, leading to chronic pain and debility. And although they both occur as we age, they have different treatments and different evaluation strategies. Osteoporosis is quite prevalent. If you look at the amount of money that we spend in this country every year for certain types of diagnoses, if we look at fragility fracture dollars spent, we spend more money taking care of patients in the hospital with fragility fractures than we do taking care of patients with MI or patients with stroke or breast cancer. And part of the reason is the prevalence is so high. 1 in 2 women and 1 in 4 men will break a bone after 50 from osteoporosis, and it leads currently to over 2 million fractures every year. The most common fracture is vertebral, followed by wrist, followed by hip. And this number is only going to increase if you look at projections over the next 20 to 30 years. Again, wouldn't be complete without one of these slides. Many of you have seen this slide because it's in our bone health playbook, but it gives us an idea of our bone mass over a lifetime. So we achieve peak bone mass generally around age 20 or 30. And we have a pretty stable bone mass, usually until menopause for women, at which point we lose a lot of our bone density for 7 to 10 years during the beginning of menopause. This can happen to a man who has androgen deprivation therapy for prostate cancer, and it happens earlier in life to women who go through earlier menopause. Hormonal changes obviously accelerate this. If you look at those graphs, unfortunately, aging continues to lead to bone loss. We know that some people have genetics that leads to their osteoporosis. Diet can be a factor, of course, physical activity and other health conditions. So now I'm going to switch gears. Jessica's going to take over and present the physical activity part of our discussion. And I'm going to come back with recipes. Oh, let me do this real quick. I'm sorry. Preventative treatment is what we all should be doing, whether we're simply at risk or whether we've been diagnosed with osteopenia or osteoporosis. It's important to maintain a normal body weight. That includes avoiding excess weight, which can lead to diabetes. We know that diabetes leads to altered bone microarchitecture and increased fracture risk. We know that being underweight leads to loss of muscle and bone. And so we need to maintain our weight, obviously avoiding tobacco and avoiding excess alcohol intake. We should get screened when appropriate with a bone density test. We should look at our 10-year fracture risk by FRAX and other studies. We need to eat well. We need to get enough calcium, ideally through our diet. Most of us need 1,200 milligrams a day after age 50. We need enough vitamin D to absorb calcium, but not too much. And of course, we need to strengthen our muscles. We need to work on balance. We need to prevent falls. And I'm really trying to stress, especially to primary care providers, that when they're seeing perimenopausal women who have risk factors for osteoporosis, if they have no contraindication, we should be discussing hormone therapy for the first 10 years of menopause for many of those women. Now I'm going to hand the baton to Jessica.
Okay, so why is exercise important? It's really for two reasons. So number one, loading the bones is the biomechanical signal that we're giving the body that it needs to lay down stronger bones. So when we use our muscles and we put weight through our bones, we're causing sort of micro stress, like stress with a little s. And that pulling on the bones helps the body know that we're using them and that it's important that it devotes some resources to maintaining them. So while it's true, most people with osteoporosis will probably need some sort of medication to help them control their disease progression. Physical activity is a really important part of the treatment strategy, and it helps make sure that you're getting the most benefit you can out of those medications. The second reason why physical activity is really important is being active and exercising regularly does decrease your fall risk. And if you can prevent having a fall, then you can you can lower your risk of having a fracture. So why I'm so passionate about activity and its role in helping treat osteoporosis is there's no pill on the market that can decrease your fall risk, only exercise can do that. So I'm going to talk about a couple of frequently asked questions that I get. Like I said, I've been working with Dr. Inscore and her team to help people who've been diagnosed with osteoporosis design a good bone loading program and make physical activity more of a regular part of their life. The first question is, how do I design an effective bone loading exercise program? So when we're looking at creating our program, this is what the evidence tells us we should be trying to include. So there's three categories of activity. I'm only going to go through these briefly. There is a lot more information about that online. We've published a resource for you. But basically, you want to be getting some movement in each of these three categories. So in the first category, you want to be spending some time weight bearing on your bones. So moving, low impact, but for a long duration of time. So that's category one. A lot of us can get this into our daily or our weekly plan by having a walking program, but it's certainly not the only way. Other things where you're weight bearing through your legs count, such as doing a treadmill or an elliptical, taking a Tai Chi class or even a Zumba class at the gym. All of those would count towards that category one. Category two involves spending some time just standing on one leg. And the good news is it still counts as a good activity, even if you have to use your hands for balance. And then category three is the one that I'll spend more time talking about tonight. And that is resistance training. That's what I find people tend to have the most questions about when they're trying to build their own bone loading program. So here's that link that I talked about. So if you go onto the Valley View website and look at Dr. Inscore's page on the provider section, she's got a nice little link to download a PDF that has a lot of information about osteoporosis and also includes some step-by-step instructions for how to build your own bone loading program. And then I always like to remind people, these guidelines may seem kind of intimidating. If you add up all those different categories, it could take you 4 or 5 hours a week to build that into your routine. So trying to get all of that stuff in may seem like a lot for people. So I like to remind people, start small and build up towards these guidelines, because even if you're not doing every one of these things, doing something is always going to be better than doing nothing at all. So if you're already walking regularly, that's great. Start there and maybe add one strengthening move a week and kind of build on your successes. Don't try to do all of this at once. Bone building does take time. So when you're thinking about exercise to help your bones, it can't be, something that you do for a couple of weeks. All of these studies that show a beneficial effect of exercise on your bone density take those measurements after 18 to 24 months of exercise. So it's really important to pick something that you like and that's sustainable for you to keep doing. Of course, exercise alone may not be enough, but it can still reduce your risk of having a fall and therefore reduce your fracture risk. I'm not going to go through this slide completely, but this is just to show you that the bone loading program is going to look different for every person, depending on what you like to do and what your abilities are. So there's no one size fits all. There's lots and lots of different options. Okay, so kind of circling back to resistance training, what type of resistance training is best? What should we be doing? And the good news is it doesn't matter. All of these methods, whether it be free weights, body weight resistance, using resistance bands, or even weight machines at the gym, all of these count. So that gives you some freedom and flexibility to choose something that you like to do and that feels good on your body. The important thing is that it's the right intensity. So you want to make sure that the resistance that you're using is heavy enough. The one little asterisk to that is some people, for various reasons, may not be able to lift heavy weights due to pain or balance problems. And we think that it still is good. If you can't lift heavy weights, then we try to do the exercises standing up when we can, so that we're also getting some weight bearing through the body. So that brings me to the next question, is how heavy does it need to be in order to be effective? So the rule of thumb that all the literature uses to get into that moderate to high intensity strengthening is technically what is known as 60 to 80% of a 1 repetition maximum. Now, Olympic powerlifters use those kind of metrics, and so that's not really something that most of us are going to use to estimate really the weight that we're lifting. And so the rule of thumb that I like to give people is you want to pick a resistance where you're able to lift 8 to 15 pounds. So if you can't do it 8 times in a row, then what you're doing might be a little bit too heavy and could potentially be more likely to injure you. But if you can do, more than 15, if you're doing sets of 20, it's probably a little bit too light and you need to go up on the resistance. Of course, if you're regularly strength training, in theory, you should get stronger. And so you're going to have to be gradually increasing your weight as you continue. So that target for you is going to be a moving target if you're regularly lifting weights. Okay, and finally, how can I safely load my bones, and are there any positions that I should avoid? So weight training is safe for people that have osteoporosis if you're staying in that kind of recommended range. And then the idea is to start slowly and kind of build up to those heavier weights. I always tell people that you want to move carefully and with purpose. You don't want to be swinging things around, so you want to stay in control of the weight. And as long as you're not having a lot of pain while you're doing it, it's probably safe for your body. There are some positions that I recommend that people who have osteoporosis or even osteopenia try to avoid. The bones in our spine tend to be a little bit more vulnerable. So we kind of have a picture here of the vertebra, and you can see that our spine naturally has these curves. So the curve in our neck and the curve in our low back kind of bend in the backwards direction, and then the curve around our rib cage and our thoracic spine bends us in that forward direction. So in the backwards direction, we have these spinous processes that are sticking out of the back, which give us a little bit of support and limit our movement in the direction, in that backwards direction, but we don't have that in the forward direction. In addition, we are oriented towards the front side of our body. Our heads are, kind of looking at the world around us. We're doing things in front of our body with our hands. That tends to lead us to having a little bit of a forward head. And the weight of that head is kind of gradually bending our spine forward. So that's a concern with weakened bones in the thoracic spine, because lots of that over time can actually change the shape of those individual vertebrae. And so instead of being these nice even cylinders, they can actually get this wedge shape where they're a little bit thinner towards the front side, and there's not as much compression in the back. That can lead to sort of this hunched over posture. And once you have those changes in the bones, it can be hard to stand up straight out of that. So because of this, these are the kind of positions that I have people avoid. Sort of anything that kind of bends your spine forward in an extreme way that you're doing repetitively, I ask people to try to avoid that. So if you're lifting a big heavy weight off the floor, we want to try to keep the back flat rather than rounding forward. A lot of people I talk to like to do yoga or Pilates, which I love. I think those are really great modalities. But there are a lot of positions that put you in kind of these more extreme ranges of motion, especially that forward flexion of the spine. So if you're doing those ab crunches or the Pilates roll up, anything in yoga or Pilates where you're trying to put the feet over the head, I think should be avoided. And then some of the more extreme twisting motions of the spine and the hip, I recommend that people try not to do. So if you are one of those people who enjoys your Pilates or your yoga class, I encourage you to continue doing that. But there are some modifications you can make to these exercises. So for example, instead of doing an ab curl or a crunch like is shown on the left, you can do some really nice abdominal work by keeping your head flat, your back engaged, and lowering one leg up and down. Same thing with some of these big spinal twists. That can feel really good on the spine to some people, but it might be putting too much torque through your spine. So instead of doing a huge range of motion, maybe do a smaller, like drop both knees side to side, which still gives you that nice rotation, but it doesn't take you to the limits of your motion. So this is something that you can always talk to your instructor with, and they might be able to suggest alternatives where you're still getting the benefit of the movement or the pose, but you're putting your spine in just a more neutral position. So next, and I hope I saved enough time for this, I'd like to show you some of my favorite exercises as part of an osteoporosis or bone loading program. So I have Maggie here. Maggie is also an esteemed member of our bone health team. So a lot of people that work with Dr. Inscore also see a lot of Maggie. She does a lot of heavy lifting around here. Okay, so the first exercise I'd like Maggie to help demonstrate is going to be an exercise that helps strengthen the muscles of your back. So when we talked about that forward posture, putting the front side of those vertebrae at risk for becoming a wedge shape, you have really nice strong back muscles that can be protective. So I can't see anyone in the audience. I don't know who's listening to this. So I just have to say that these exercises work for many people, but they don't work for everyone. And so if there's something that we're demonstrating here today, that if you're trying at home and it doesn't feel right, there's other ways to get that benefit. And so you can talk to a healthcare provider about that. So don't push yourself through anything that doesn't feel right. But I talked to Maggie and she says that she's okay to try this one today. So Maggie, would you please lie on your belly? Not everyone can lie down on their belly. Some people feel too much strain in their low back in this position. Is your low back okay? Yep. Okay. If that's you, I recommend putting just a pillow underneath your waist. That can take some pressure off the low back. Okay, so what Maggie's gonna do is lift her head and shoulders a little bit up. You see how her elbows are nicely tucked in by her side, and actually come down just a little bit more so she doesn't have to come up super high. Her abdominal muscles are engaged. She's keeping her back really supportive. And this motion, she's almost trying to bend more in this part of her spine than in the low back part of her spine. Do you feel those spine muscles engaged? Yeah. And so this is an exercise that when you're starting out, you can just press up and down kind of gently. It can be a nice stretch for this part of the spine that doesn't always get a chance to bend in that direction. And then as you get stronger, you can try to hold that position and even maybe hover the hands, lift those up. Beautiful. So Maggie is very strong. She's very good at this exercise. Excellent. So that is one of my favorite back strengthening exercise. Okay, good. Go ahead, stand up. And then we're gonna grab this pole over here. So the next two exercises are not fancy. Squats and planks. They're two of my favorite exercises because both of them do a lot. But I wanted to talk about them in the context of using those back muscles to find really good posture with them. If you have the range of motion in your shoulders to do this, and again, not everybody does, but you can take a dowel or a yardstick. And so she's gonna place this along her spine. So one hand is gonna hold it above, good. And so when you, good, and we can see it nice. And so she's got her head and she's got this middle part of the back right here, as well as her tailbone touching the rod. So this is gonna give her feedback about being straight up and down. So it's a really nice job to check your alignment. If you can't reach your head all the way back to the pole, some of us don't have the range of motion in our neck for that, that's okay. Just try to pull it comfortably back as best you can and keep it in line with the rest of your spine. But the most important here is the hips or the tailbone area and that middle of the back. So Maggie, I want you to kind of do a hinging forward motion. So you're gonna bend your knees like you're doing a squat. And then just try to keep your back lined up with the rod. Good, very, very good, and come back up. So again, when she does it nice like this, she's using those back muscles to help support her spine, even as she's bending forward. So this is how I would recommend she try to bend forward to pick up something off the floor. She's keeping her back nice and flat. She's not rounding it too much. And that's great. So we're gonna keep that stick to move into a little squatting motion. So not everyone likes squats. I love squats because they work a lot of different muscles of the body and the lower leg, I mean, and you don't need a lot of equipment for it. So I'm gonna have Maggie demonstrate a progression. So go ahead and have a seat in the chair, and then I'll hold the stick for just a moment. Okay. So level one is standing up from a chair, and some people might need to use their hands to help them up. So Maggie's gonna lean forward and push up with her hands. Good. And that's sort of the first level of doing a nice squat. That was beautiful. Well done. So if we use our principle of trying to find a resistance where we can do 8, but we can't do 15, I'm not gonna make Maggie do that many sit-to-stands right now, but I'm assuming she could probably do more than 15 of these in a row. So we need to make it harder for her. So I'm gonna have you do the same thing with no hands, so that's a little bit harder. And would you please put the stick in the same place you had it before? Yes. Okay. So she's gonna try to stand up, keeping her back aligned. Good. And if you can, try to keep that middle part of your back aligned too. Good. And go ahead and sit down better. Very nice. Okay, so this is the next level of a squat. Okay, what's nice about this is if you're just kind of getting into squatting, you have the chair there. And so, if you're concerned about your balance or whatever, you want to make sure that chair is pushed against a wall so that it doesn't sneak away from you when you're trying to sit down on it. But it's a good place where your muscles can take a break. They can take a little rest in the middle of the squat. So do you feel like you could do more than 15 of these? I think so. So too. Okay, so the next level is doing the same motion, but instead of letting her hips rest completely, she's just going to touch the chair with her bottom and come back up again. So try that. So she's going down, she's keeping nice smile alignment. She's just going to tap and go. And that just takes out the rest break. So that is a little bit harder. Okay, need the next level, Maggie? One more? Okay.
The stick.
The stick is
good
a lot
reminder.
harder.
It's harder.
Yeah, it's much harder.
Yeah.
Okay, so we're gonna lose the stick.
Okay,
and
great.
so at this point, when you get really, really good and you can do a lot of sit-to-stands like that, then you add resistance. So I'm gonna give her 4 pounds. I would probably say you could do this with at least 20. but I didn't want to carry that much weight up on my chest tonight. So hold those weights in close to your body. You're gonna do the same motion, pretend like you still have that stick, and you're just gonna do a tap and stand. Good. And there you kind of, and once you can do this, then I just, progress that weight that you're holding until you're really feeling some good work in your leg muscles. So the front of the thighs, the back of the thighs, maybe the seat. And that's a good strengthening exercise for the legs.
Should I always hold them here or my arm down here?
So you could, but I would want you to keep them close to the body and not too far away. Sometimes I also have people do a little press at the top to get some upper body, but that's optional. So you can stand, do a nice little press. Excellent, good job. Okay, do we have time for one more? Wonderful. Okay, I'll take those. So I do love planks. And that's because they're sort of like a squat, but for the arms. They're using a lot of different muscles. It's also a really nice chance to get some load bearing through the wrists. And that's a very vulnerable place in terms of weakened bone. So that's what I like. So I'm going to do the same thing where I kind of show a little progression from like an easier level to a more difficult level. So what we'll do, I'm hoping, we'll use that. And then I'm going to move this chair out of the way. And then we move this table, I'm hoping, okay, they'll be able to see you. I wanted you to show kind of a plank on the countertop. Okay. Do you have enough space for that? I'll take this. So if you have like a kitchen counter or, a sturdy piece of furniture, plank on the counter is a really nice place to start. And then we can do our same little trick of lining. This is harder. You can't really hold this on yourself. So you need a buddy like me to hold it for you. And then this looks really good. Maggie, can you do a push-up? And then she's just going to keep her back straight the whole time. Gorgeous. Let's kind of slide around with it more. Good. And so that's a really nice way to get started with push-ups. But again, this is too easy for Maggie. So we're going to take you to the next level. So a nice progression from here. It's a long way from the counter to the floor. So when you're just getting started on the floor, if your knees are okay with kneeling, I recommend starting on all fours. And you can certainly put some padding under your knees or use a yoga mat. And if the wrists, this is a squishy surface and it kind of is making the wrists have to bend a lot more. If you have wrist pain with this, if you have little hand weights, you can use those to kind of get your knuckles up and straighten those wrists out. Okay, and then come a little bit further forward so you can tuck your toes. So the first step here, go ahead, tuck your toes and lift your knees and hitch. Good.
Hard.
And this is hard, but you're not too far away from the floor. And then we're just checking your alignment and it's excellent. And then you relax your knees. So this is great for the arms, the shoulders, the wrists, and probably some core, I imagine, getting some core in. Quads. And some quads. Okay, good. And then from there, we go into a full plank. So you can stretch one leg out. So you have space on the table. Yes. And then the other. Good. And the first step might be holding this. And Maggie doesn't have to do a full push-up if she doesn't want to, but if you do these all the time, you can do it. And yep, there she goes. Wonderful. So strong. And that's how you kind of work yourself gradually into a push-up. Really, really good work. Thank you so much. So those are some of my favorite little exercises. And I think Dr. Inscore is going to come back and talk to us about some recipes that are high in calcium.
Right. So here are a collection of calcium-rich recipes that we came up with. As we talked about, we need 1,200 milligrams of calcium a day if we're over 50, and ideally we get that calcium from our diet. Here is a great vegan recipe with broccoli and kimchi. It comes out of, I love eating well, which used to be cooking light, but that's what this comes out of. And if you look at the bottom of the recipe, maybe we didn't put it in here, but it contains 40% of your daily calcium requirements because of the high amount of calcium in both the tofu as well as the broccoli. So that's a great one. Here's how to make it. All the directions are here, and yeah, we're going to share all of these recipes. This is not vegan, but I have never had soy-based bacon. Can you make a good soy-based bacon? Because you could probably use that in this recipe. The vegetable with the highest amount of calcium, anybody want to guess? Collard greens. So collard greens have 278 milligrams of calcium in a cup of cooked collard greens. One of our questions on the forum today was about spinach and the oxalates that are present. So spinach does have oxalate. Oxalates can increase our risk of kidney stones and interfere with calcium absorption. But cooked spinach will help break down that oxalate. So if we have a history of kidney stones, or we simply want spinach to be a big part of our calcium intake, we're probably going to cook it. Other greens such as kale and collards, you don't always have to cook them to release the calcium because of the lower amount of oxalate. But I don't think you're going to eat raw collards, although there is a recipe for a salad in there. This is a great recipe that I found a couple months ago with collard greens. And again, it's not vegan, but it's primarily bacon, and it's got vinegar and a bunch of other things in it. And it probably has around, depending on how much, 1 cup is going to give you almost 300 milligrams of calcium. So that was one of the things I wanted to share with everybody today. I also needed to read our end of our talk disclaimer. Where there will be some questions that we'll try to answer either now or through the or do it online. And we're happy to hear feedback from today. There's apparently a quick survey that you can fill out if you're happy to do that. And then we're gonna send everybody an email with the recording of the webinar, and it will include those recipes at the end. And we want to remind you that our next VVU is going to be Thursday, May 29th at 12 at the Callaway Young Center with Dr. Donovan, and she's going to be talking about skin cancer. So that's the next one. Thank you all, and I think we're both going to come up and try to answer some questions.
Yeah, so I'll read a couple that we have already. I think that we saw this one on Dr. Inscore already. So they were asking about oxalates and
Yeah, so again, oxalates can bind with calcium. It's one of the reasons that we have said to patients for years that if they have a risk of kidney stones, that a high calcium containing diet will frequently bind with the other oxalates in their diet, thereby reducing kidney stone risk. Oxalates are present in some of the greens, as we talked about. And again, the raw spinach is going to possibly reduce your calcium absorption simply by, again, oxalate binding to calcium in our diet. Doesn't mean we're not going to eat it, and again, one of the things that we do in the bone health clinic that helps us prove that patients are getting plenty of calcium in their diet is we do a 24-hour urine calcium level, and that will help tell us if your average diet is giving you enough calcium with or without a supplement. The resource book that we mentioned, I think, is online.
yeah, quite a few people asked about the patient playbook that we have, and it's on our website. We can also send a link in the follow-up email tomorrow directly to that if you're having trouble finding it. But you can go to vvh.org and look up Dr. Inscore's provider page, and you'll be able to download the playbook there.
There's a vitamin D question. I'll answer that. Vitamin D is required for calcium absorption. And if we're not taking any vitamin D at all, about 40% of us have insufficient levels. A smaller percentage are deficient. A normal vitamin D level is 30 to 100. And ideal when you're at risk for osteoporosis, you want your vitamin D level to be The experts are generally recommending somewhere between 35 and 50. You want to be at least in the mid-30s. I usually tell patients that the best place to be is probably between 40 and 50 because it prevents us dropping down in the winter months. If you don't have osteoporosis and you're not at risk, having a vitamin D level of 30 is probably perfectly fine. But for those at risk, we like to see 40 to 50. The most effective type of calcium supplement, you know, a lot of patients do want to find what they perceive to be the best calcium out there. Again, dietary calcium works just as well. It's just harder for people to get 1,200 milligrams day in and day out. So there was a study many years ago showing that chewable calciums were better absorbed than solid pills. But again, the 24-hour urine calcium that we obtain proves to us that you're getting enough calcium. We frequently cut back on our patients' calcium supplementation because many patients that find out they have osteoporosis tend to sometimes overdo their calcium supplements and or their vitamin D. So it's not uncommon that we evaluate patients and have them back off on some of the things that we're doing. But it's generally recommended that patients take somewhere between 1,000 and 2,000 IUs of vitamin D daily, and that it equates to 25 to 50 micrograms.
There's another question, wondering if we know anything about the Onero program based in Australia or Dr. Belinda Beck for the OsteoStrong.
Yeah, I have heard some about the OsteoStrong. I'm happy to do some research and answer that one online.
Great. And then there was a question about EchoLight Medical. It's a sonogram-based technology with no radiation and gives you a fragility score in addition to bone density.
I have seen that. I think it's just in its early stages. I haven't seen it presented at a conference. I don't know if you saw it this year, but I have seen it. I think it's just too early to know yet.
And then looks like just a couple more. One about vibration plates. Wondering if vibration plates increase bone density and if there's any scientific data to support that.
There was a lot of talk, I want to say about 20 years ago. There was a professor from Germany that brought all of his vibration data and information. And there is some positive data. Amanda and I just looked it up when that questionnaire came through, and it sounds like there is varying data in the literature, some positive and some negative. What I tell patients is if you choose to do that as part of your activity, I think it's probably beneficial. But don't exclude the active things that Jessica's focusing on, because those I think are the most important. We're not going to get as much as we need standing on a vibratory surface as we do moving around, standing on one foot, practicing our balance all day long.
I would agree with that. I think there's just not enough evidence for them to add that into the formal recommendations of something that you should be doing. There are some contraindications, so a lot of times we try to avoid that. If people have had a joint replacement, just figure the risk of vibration and loosening hurts. And so a lot of people that are of the age of osteoporosis do have joint replacements, and so just be aware of that.
Okay, I think maybe two more. So one question about if they have a high coronary calcium score, how much calcium through a supplement is safe?
You know, it's unclear. I heard an echo talk, actually it was a ViewMed talk about 3 or 4 weeks ago, stating that some of the information that became available probably now 8 to 10 years ago, we've always had some concern about calcium supplementation, especially excess calcium supplementation in patients at risk for kidney stones. But about 10 years ago, there became more concern about the vascular calcification risk of calcium supplements. The data isn't entirely clear, but the most recent woman that I listened to said that much of that data has been looked at and probably is not very strong. The kidney stone risk is real. The coronary calcium risk is still relatively unclear. What I tell patients is that if you do have a very high coronary calcium score, and especially if your cardiologist or your neurologist is counseling you to avoid calcium supplementation, then you really need to work hard to get it all in your diet. It can be done. It just takes more work to get it day in and day out.
Okay, and then I think one last question was just about a DEXA measuring bone density, but wondering about how to measure bone quality. I think you kind of mentioned that, but maybe just.
So we have said over the years that bone density, which we can measure with a DEXA, and bone quality are not the same things. And we have always said that if you have had a fragility fracture, especially more than one, that by default, probably your bone quality is not good. We have a new software that's in our DEXA machine. I think we are the only facility on the Western Slope offering trabecular bone score with our DEXAs, but it can be ordered even after the DEXA has been performed. So TBS, trabecular bone score, looks at your lumbar spine. If you cannot have a lumbar spine DEXA, you cannot have a TBS because it's only done on the spine. That could be in the case of, say, hardware in your back. But for anybody that has a measurable density of the lumbar spine, we can add a trabecular bone score, which gives us a measure of quality. It's not perfect, but it's been shown to correlate well with increased fracture risk in patients with low bone quality. And we've also been very, seen the positive effects of our bone building drugs increasing that number. So the trabecular bone score in our little world of study goes up when we give patients a bone building drug and we can measure it and prove and show them that they've had a success not just in raising their bone density, but in raising their bone quality.
Great.
And that's it. Thank you all for coming. And we look forward to seeing you in the clinic.